Thank you for joining us today, and welcome to today's live broadcast, the Molecular Pathology Perspective of the CDC's Infectious Diseases Pathology Branch. I am Judy O'Rourke of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. This webinar is sponsored by SciEx, placing the power of life-changing answers into the hands of those who care everywhere. For more information, please visit sciex.com. Before we start, there are a few instructions. We want to hear from you during this interactive broadcast, so please ask questions or leave us a comment. Answers are welcome too, and you can do this by hitting the green Q&A button at the lower left of the presentation window and typing in your comments and questions. We'll try to get to as many as we can, and we'll follow up if we don't have time today. Want a better look? You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you can't hear or see this presentation properly, let us know by clicking on the support button at the top right or use the Q&A button. We'll make sure we try to resolve any issues. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of your web page and follow the process of obtaining your credits. Now let's get right to today's presenter. We are proud to welcome Dr. Amy M. Denison. Dr. Denison is a microbiologist in the Infectious Diseases Pathology Branch of the Centers for Disease Control and Prevention, the CDC, in Atlanta, Georgia, where she develops and performs diagnostic assays to assess infectious diseases in formalin-fixed, paraffin-embedded tissues. Much of her work has focused on viral respiratory diseases, especially influenza, as well as tick-borne diseases like rickettsia rickettsii. As a postdoctoral fellow at the CDC, Dr. Denison studied the bacterium Coxiella burnetii, assessing genomic variation between different archived strains. Dr. Denison received her PhD degree in molecular and cellular pathology from the University of Alabama at Birmingham, where she examined surface protein variation in Mycoplasma pulmonis. I will now turn the presentation over to Dr. Denison.
Thank you very much, Judy. I appreciate the introduction, and I'm glad to be speaking with you all today. Well, today I'm going to give you a little bit of background on what we do here at the CDC in the Infectious Diseases Pathology Branch, and specifically in the molecular pathology team. So if we go to the second slide, while many groups here at the CDC focus on a specific pathogen or specific related pathogens, say the influenza division or the rickettsial zoonoses branch, the things that tie us together here in the Infectious Diseases Pathology Branch are really the pathology that we see in tissues and whether there's an infectious disease-related process that we're seeing in those. So primarily what we look at is autopsy tissues, but occasionally we do receive biopsies and surgical and veterinary tissue specimens. It's our mission to provide support to state health departments, clinicians, medical examiners, pathologists, international collaborators, as well as assist the subject matter experts here at CDC in investigations that are ongoing. What we really do, the heart of our work, is we investigate outbreaks of unexplained etiology. So the next slide gives you a little idea of our specimens and the submission process. What we look for is the process of an infectious disease in the tissues as suggested by clinical, epidemiological, and our pathological findings. So typically the clinician or the medical examiner will see something on the histopathology of the tissues, and that will be suggestive of an infectious disease process. Again, with the clinical history, typically sudden death without a fever or a prodrome is probably not going to be an infectious disease process. It's also helpful that we get all of the clinical information along with these cases so that we have an idea of exposure history and any other lab findings that were found if they were in the hospital for any length of time. The types of tissues that we typically receive here then, we do get some non-fixed frozen tissues, and those can be used for PCR and for culture isolation. Oftentimes portions of those are then fixed in formalin and are processed into paraffin blocks. However, we can also receive just formalin-fixed tissues, or what they call wet tissues, but ideally those need to have been in formalin for less than a month. We also will receive paraffin blocks, and we can do on those immunohistochemistry, PCR, as well as electron microscopy. Unstained slides can also be sent to us, but we can only do immunohistochemistry on those. We cannot do PCR or electron microscopy. If we receive other non-tissue specimens, say blood or CSF, we typically will share those with a specific subject matter group here at CDC as needed. So moving on to the next slide, what happens when we receive a specimen here in the Infectious Diseases Pathology Branch? We accession those into a database so that we have some control of the information so we can keep the specimen clinical information together along with what types of samples we received. Any fixed tissues that we get are then processed into paraffin-embedded blocks, and then we will cut sections from those paraffin-embedded blocks for histology. And H&Es then are then viewed in sign-out, which happens every day here in the Infectious Diseases Pathology Branch. And based on the clinical history and what is seen in those H&Es, special stains, immunohistochemistry testing, as well as molecular testing can then be requested. All of the testing we keep track of in a central internal database, which helps the pathologist in the end to assemble a report that is then sent back to the submitter when all of the testing is complete. However, formalin fixing these tissues has its drawbacks when it comes to molecular pathology. So formalin fixation and paraffin embedding results in three things that are potentially negative towards the nucleic acids within the specimen. One is oxidation. The air over time can affect and degrade the nucleic acids in the sample. In addition, formalin, it fragments the nucleic acids as well as cross-links and chemically modifies the nucleic acids. So to exemplify that, I have a slide here that shows a gene sequence, and it shows in the very early portion of that gene sequence, the first fragment, say if we have 4 bacteria total, the first one ends up having a fragment that's quite short because of fragmentation due to formalin. If you see the yellow dot then in the middle, that's a DNA protein cross-link in what would be the third bacteria. And in the second, we have another fragmented portion that's shown by the green line in the second bacteria. So of the 4 that we have, only one of them has an intact gene. So you can see here that due to this process, we just reduced our sensitivity to 25%. So we have a few techniques that we can use to try to overcome those, but it is something that we have to be aware of when we're working with these types of tissues. So moving to the next slide, this is slide 6. Oxidation, or just the air affecting the samples, this is going to be something that happens over time. So older samples are more difficult to obtain quality nucleic acids from. But if the specimen was fixed in formalin for a short enough period of time, we have been able to examine decades-old material and gotten quite nice results from it. Some of the factors that are involved in the fragmentation, cross-linking, and chemical modification, as I just mentioned, the time in the 10% neutral buffered formalin is really key. We really like to see that less than a month, but really less than 2 weeks is preferable. We've had one rare case that was positive for flu by real-time RT-PCR after 6 months, but that is an extremely rare situation. So our recommendation is that after no more than 2 weeks, samples be transferred to 70% ethanol so that they can be stored longer term. Elevated temperatures during the embedding process to create the formalin-fixed paraffin-embedded tissue blocks can also result in these negative factors, as well as we've seen the quality of formalin. There have been some countries that will send us specimens and their formalin has heavy metals or is impure, and it results in our inability to get decent nucleic acids from these tissues. So how do we go about extracting nucleic acids from the formalin fixed paraffin-embedded tissues. Well, you can see here on the right, this is a picture of a tissue block. This is slide 7. And we use a microtome to slice a 16 micrometer section from that, and we put that in an Eppendorf tube. We then remove the paraffin using xylene, and then wash twice in ethanol, and then dry the tissue pellet. And once it's dried, and it needs to be very dry, that is, we digest that overnight in proteinase K and buffer. The next morning when we come in, we have an elevated heat step that we use. For RNA, that's at 80 degrees Celsius for 15-minute step, and the DNA is a 70 degrees Celsius for 10-minute step. And what this does is not only inactivating the proteinase K, but is also helping to reverse some of that cross-linking. The overnight digestion is also part of that process. Once that's done, we use the QIAGEN chemistry for DNA. We have a QIAGEN UCP kit that we use to isolate the DNA. If we're going to do a real-time RT-PCR assay for this, we will then use an EZ1 robot that's made by QIAGEN in order to extract the RNA. But in certain situations, especially if we're doing conventional RT-PCR, we will still use a traditional phenylchloroform method to isolate RNA. So moving on to slide 8, we will quality control check all of the nucleic acids that we are using. The DNA we will check with a multiplex PCR that looks at both beta globin, that's a 200 base pair fragment, and GAPDH, which is a 500 base pair fragment. And this gives us an indication to the level of fragmentation of the specimen that we have. So if we have something that's positive for the 200 base pair but negative for the 500 base pair, we know that any assays that we have developed that are greater than 200 base pairs expected for the amplicon may not work. So we, in the end, may report out an inadequate tissue specimen as a result. For RNA, if the specimen is going to be analyzed by real-time RT-PCR, we use a beta-2 microglobulin RNA-specific housekeeping assay that's 75 base pairs. Or if we're using it in a conventional RT-PCR, we have an 18S rRNA. It's actually a commercial kit that we use. It's a 324 base pair assay. So when we actually are then moving on to assessing for specific pathogens that are found in these tissues, how do we go about designing primers? Well, what we want to do is look for a region that's conserved, but at the same time it needs to contain enough variability so that we can use Sanger sequencing to differentiate it from other, say, related viruses. So if we were looking at flaviviruses, for example, we want conserved regions on the 5' and 3' ends where the primers anneal, but in the middle, when we get a sequencing result, we want to be able to use the variation that's found in the middle to find the specific flavivirus if we can, whether that be dengue or Zika or something else. We also want these to not match human sequences if at all possible, or if it does match some, it needs to be different enough in size that when we run these on an agarose gel, we can size select what we're looking for and excise that from the gel. We also, as a consequence of the level of fragmentation, look at very small amplicons. So we typically are going to go less than 500 base pairs if at all possible when we design these primer pairs. So moving on to the next slide, slide 9, there are some assays that we do where we use real-time PCR or real-time RT-PCR, and some of these we even have the ability to then run on an agarose gel and sequence them. So shown here on this slide is just the overall amplification plots from an influenza run that I did recently. And if we move on to slide 10, these are the actual results that show you sort of how the plate is set up. And we have 6 different targets that we look at. In row A across the plate, that's the housekeeping control, the beta-2 microglobulin housekeeping. And we also have in row B a target for flu A, in row C a target for swine A, and in D a target for swine H1. And all 4 of those taken together, as you can see in column 7, if all of those are positive, those are the key gene targets that are needed to be positive in order to say that that particular case is positive for 2009 pandemic influenza A H1N1. We also have targets for H3 as well as flu B, so we have a way to check and make sure that we have multiple positives here and can determine that we have good quality nucleic acids and can say whether we have a positive or negative case for influenza. And moving on to slide 11, when we have to do conventional PCR or real-time PCR, we will run the reaction and then run that on an agarose gel. As I mentioned, we will then excise the gel band of the appropriate size, and we process those with a QIAGEN Min-Elute gel extraction kit. And once we have eluted that, it's in a typically small volume, anywhere between 11 and 30 microliters. We will take that gel extract, and a portion of that will be run in a cycle sequencing reaction. We use the Beckman-Coulter GenomeLab GeXP, so we use the Beckman-Coulter sequencing chemistry in order to do our sequencing reactions. And that uses what they call a DTCS quick start kit, so it's a dye-terminator cycle sequencing. And essentially, you are taking a master mix, you're adding in a primer, and then you add in your amplicon and run a cycle sequencing reaction on that. When that's completed, we use a QIAGEN Diex kit in order to remove the unincorporated nucleotides and then place that in a speed vac until it's dried. Within that quick start kit, there is an SLS solution, which is essentially formaldehyde, and that sample is then resuspended in the formaldehyde, put into a 96 well plate, and a drop of mineral oil is added. And the beauty of the Beckman-Coulter GenomeLab GeXP, to me, is the onboard denaturation. You put your plate on the sequencer, and it does everything else for you thereafter. So the denaturation and capillary electrophoresis. We then will export the sequences from the GenomeLab GeXP into the QIAGEN CLC main software program. We'll trim the sequences and create consensus sequences if we were able to get both forward and reverse sequences. And those consensus sequences are then submitted to NCBI's BLAST, where we can determine what we have and what's the highest identity to. So moving on to slide 12, just to give you an idea of the different pathogens that we are able to look at. We have run thus far, up until September 1st, about 3,500 molecular tests this year. A vast majority are to respiratory pathogens like adenovirus, influenza, mycobacteria I'll be talking about here shortly, parainfluenza viruses. We have assays for parainfluenza viruses 1, 2, 3, and 4, RSV, staph, and strep. We have some STDs, some GI, vector-borne pathogens like rickettsia, which I'll be talking about shortly as well as others that don't fall neatly into some of these categories like enteroviruses and Trophorema whipli. We also have a very nice broad-range 16S rRNA that we can use to try to identify cases where we aren't particularly sure what specific pathogen might be in the specimen, but it looks like it's bacterial in nature. So moving on to slide 13, one of the components of the work that we do here in the Infectious Diseases Pathology Branch is look at unexplained deaths, and we cooperate with a couple of different states on unexplained death investigations. So one state that we have a close relationship with here is Minnesota, and this case that I'm going to present to you came from there. This is a 1-week-old female who was found deceased in their bassinet. At autopsy, the medical examiner found myocarditis, but very little else in the tissues. And the heart tissues did indeed demonstrate a marked inflammation. There were lymphocytes, some histiocytes, as well as neutrophils, but the gram stains were negative, implying that this was a viral infection. Immunohistochemistry was requested, and a pan-enterovirus immunohistochemistry was performed, and the antibody cross-reacts with many viruses, including the enteroviruses. So at that point, molecular testing was requested, and this particular assay is a conventional RT-PCR assay, and primers recognize the most common enterovirus group species, and this targets the 5' NCR of the virus. So on the right-hand side of the slide, you can see an image of the gel. This is a 231 base pair fragment. You can see the positive control, a no template control or water control, and then the positive case on the right. The band from the positive case was then excised from the gel, and if we go to the next slide, the GenomeLab GeXP data are shown here. You can see on the top the actual sequence data and the raw data on the bottom. And if we take this sequence data and we export it into CLC, where we trimmed it up a bit, and then sent that through the NCBI blast, I got a very decent hit in terms of the way enteroviruses go, a 96% or 98% hit to human Coxsackie virus B5. And we additionally shared this specimen with the picornavirus group here at CDC, and they were able to indeed confirm that this was a Coxsackie B5. So moving on to another unexplained death investigation that we did. This was a 24-year-old male who was a cruise line employee, and they had spent 16 weeks on the eastern-western Caribbean route and then went to Indonesia for 8 weeks after the ship docked. They had had a 6-month history of diarrhea, and when they returned for work, within 2 hours, they had diarrhea, high fever, and vomiting. They ended up having to be transported to the hospital off of the ship and died 2 days later. The hospital tests for strep, flu, malaria, and methicillin-resistant Staph aureus were all negative, so they sent liver and respiratory tissues, kidney, brain, heart, and GI tissues here to the Infectious Diseases Pathology Branch. The immunohistochemistry for dengue virus was performed. It was negative. And another rule out was influenza, so I performed RT-PCR on the specimen, and it was also negative. However, the conventional RT-PCR for dengue was indeed positive, specifically for dengue virus 3. So these are the kinds of things that we look for here in the Infectious Diseases Pathology Branch. Now, one of the things that we have seen a lot recently is the outbreak with Zika virus. So on slide 16, you'll see a specimen that came in as a suspected Zika case. It was an infant born with microcephaly in March, and the mother had a history of travel to Panama during their first trimester. However, the Zika immunohistochemistry and RT-PCR were all negative. There were gram-positive cocci noted on a gram stain, so PCR for Streptococcus was requested, and that particular assay looks at the Streptococcus 16S rRNA. And again, you can see the data here on the slide where we have a very nice sequence data, and very interestingly, that was a perfect match to Streptococcus agalactiae, a group B strep. We do also test for Zika, as I mentioned, and just to briefly mention it, it is a conventional RT-PCR to the NS5 gene, and it differentiates the Asian from the African serotypes by Sanger sequencing. And you can see by this picture, it's a very short fragment that we're able to sequence, but we are indeed able to get very nice sequence data from these cases. So moving on to slide 18, more outbreak investigations that we look at include mycobacteria. And a lot of these specimens are very important in the fact that it's necessary to distinguish Mycobacterium tuberculosis from other types of mycobacteria because the treatments do differ. And with Mycobacteria tuberculosis, there are several drugs which are possible drugs that are resistant, are found to be resistant, and it's very important then for treatment of the individual as well as treatment for contacts. The case that I'm showing here on slide 18 is actually a fatal case, and they died from acute renal failure in California in 2015. At the time of their death, there was no clinical suspicion of Mycobacterium tuberculosis. They were a 64-year-old male who had low blood pressure, again, acute renal failure, epigastric pain, and weight loss. Bronchoalveolar lavage was performed, and the acid-fast bacilli stain on the smear of that was negative, as was the culture. They were not in the hospital for long and unfortunately died quickly. At autopsy, there were many histopathological features of disseminated tuberculosis in the lung, liver, and spleen that were shown. So you can understand that there were many concerns then for drug-resistant tuberculosis. So there were no other specimens available except for the formalin-fixed paraffin-embedded autopsy tissues. So we took those and performed the H&E stains. As you can see on the left on the slide, there's granulomatous inflammation as well as necrosis in the pulmonary parenchyma. And on the right, an acid-fast bacilli stain, which is a Zeal-Nielsen stain, is showing in the little purple dots the acid-fast bacilli. The immunohistochemistry is shown on the bottom, and you can see the red darker staining. Those are mycobacterial antigens in the granulomas. When the molecular pathology team did their handiwork, Mycobacterium tuberculosis was indeed identified by PCR, and we work very closely on mycobacteria cases with the mycobacteria group here at CDC, and they do all of the multi-drug resistance testing. So fortunately, this was a case that was not drug resistant. If we move on to the next slide, slide 19, we are looking at a case where they were trying to determine whether this was tuberculosis or not. Again, it was a fatal case due to pulmonary failure in Delaware of 2013, a 61-year-old who died suddenly during deployment to Afghanistan after coughing of blood. They'd had a previous history of carcinoma a few years prior. At autopsy, there were cavitary lung lesions, pulmonary hemorrhage, so there was a concern at that point for drug-resistant TB, especially because he had 22 contacts in 4 different states as well as overseas. Fortunately, this one turned out to be a case of Mycobacterium avium complex species by PCR, and therefore the tuberculosis was ruled out. Another very similar instance, this one where we got a very minute specimen, as you can see on the bottom of the slide how small that tissue specimen was. This is from Ohio in 2013. It was an 18-year-old woman who had nodular Hodgkin's disease, so they were indeed immunocompromised. They had multiple lesions in the spleen, and a core biopsy revealed a few acid-fast bacilli. So the question at this point is, do they continue with chemotherapy or do they undergo tuberculosis treatment? Well, the cultures for mycobacteria were negative, and the quantiferon test for mycobacteria tuberculosis was negative. So special stains and immunohistochemistry were performed here in IDPB, and those were negative using the FFPE tissues. However, the molecular group was able to perform PCR and did get a positive, and again, it was a Mycobacterium avium complex species, and they were able to then continue on with their chemotherapy. Moving on to slide 20, this is a bit of an outbreak. It started out with a single case and then quickly became an outbreak in New York City actually. It started with an 81-year-old Chinese woman who had subcutaneous nodules on the hand and dorsal wrist, and they had handled raw fish for cooking. So the question was, is this Mycobacterium marinum or another non-tuberculosis mycobacteria? It was culture negative for bacteria and fungi, and it was indeed positive by PCR for Mycobacterium marinum. Subsequently, more cases were then identified, a Chinese woman who handled live or raw fish, and we ended up getting 24 cases evaluated here in the Infectious Diseases Pathology Branch. So moving on to slide 21, I'm going to move into how some of our work translates into projects that we work on. These particular slides next are going to be talking about spotted fever group Rickettsia. These are obligately intracellular gram-negative bacteria and are spread by vectors including fleas, ticks, and mites. There are 9 named species endemic in the United States, but 3 are really the root cause of rickettsia infections in the United States. So Rickettsia rickettsii, which causes Rocky Mountain spotted fever, or RMSF, Rickettsia parkeri, which causes Rickettsia parkeri rickettsiosis, and Rickettsia acari, which causes rickettsial pox. On this slide, you can also see a picture of a yolk sac that they use to grow Rickettsia rickettsii, and all the little dark purple dots are the Rickettsia rickettsii in the yolk sac. Moving on to slide 22, typically these specimens that we use for rickettsia assessment are skin biopsies. So you can imagine they're very small tissue specimens. So the nice thing about having an FFPE tissue block like this is we can do a lot of different tests, but at the same time, because there's not a lot of tissue, while we may have 5 tests available, we only have enough tissue for 3. So the number of tests that can be performed is limited. As I mentioned before, we have some of those drawbacks with FFPE tissues, with oxidation and formalin fixation, but they're great for shipping. You don't have to refrigerate them. They're non-infectious. So if we move on to slide 23, just a little bit of background about Rocky Mountain spotted fever. It's a rather nasty disease with a pretty high fatality rate if there's no treatment. You can see the worst being in the Bitterroot Valley of Montana, which had a 63% case fatality rate in the early 1900s. One of the more recent, in 2002 to 2004, there was an outbreak in White Mountain, Arizona, where it had a case fatality rate of 12%. Moving on to slide 24, this just shows the incidence of Rickettsia rickettsii throughout the United States, and you can see that the belt in the middle of the United States where the highest incidence occurs, but there are many areas throughout the United States that are affected by Rocky Mountain spotted fever. Moving on to the next slide, slide 25. There are 3 different ticks that transmit Rocky Mountain spotted fever here in the United States. Pretty much every aspect of the continental United States is affected by one tick or other that can spread this disease. In slide 26, the symptoms of Rocky Mountain spotted fever, it's quite severe, a very high fever, headache, nausea, vomiting, muscle aches, and a rash that may take 3 to 5 days to appear if it appears at all. One of the differentiating factors with Rocky Mountain spotted fever is you do not get an eschar at the site of tick attachment. And I'll show you some pictures of eschars here in a few moments. The bacteria in this case localize and multiply in the endothelial cells of the small and medium-sized blood vessels so that you end up getting vasculitis, which is the cause of the rash. But you will get vasculitis systemically. Moving on to slide 27, it's a rare disease and it's missed quite often on initial evaluation in 60 to 85% of the time. Because it's a tick-borne disease, it's seasonal, so 90% of the cases are found between April and September, and 60 to 70% of the people will remember a recent tick bite. The problem with this disease, though, is that it's rapidly progressive, and you will be severely ill within 4 to 5 days, maybe about the same time that rash is starting to appear, if it shows at all. And the therapeutic window for the best outcome is really narrow. It's really within those first 5 days. Most of the deaths, when they occur within 7 to 9 days after onset. It's just miraculously fast, sadly fast. So untreated disease has very devastating consequences. Moving on to the next slide, slide 28, it shows the rash of a patient with Rocky Mountain spotted fever as it compares to Rickettsia parkeri rickettsiosis. And you may say, well, what's the differentiating factor here? That's the issue. There is no differentiating factor. You cannot tell the difference between these 2 rashes. So all you can say that it looks like a rickettsial disease, or it might actually look like many other types of diseases too, as we'll discuss in a few moments. On slide 29, then, Rickettsia parkeri rickettsiosis is found more in the Gulf Coast area of the United States, southern parts of the United States, and it is oftentimes associated with an eschar, and that's what's shown on the bottom right of this slide is a picture of an eschar. That also looks like many other things, as you can imagine, and I'll show another slide in a little bit that will discuss that. So if there is no eschar present, as happens sometimes, you can see on slide 30 the clinical features that compare Rocky Mountain spotted fever with Rickettsia parkeri rickettsiosis are quite similar. Both have fever, both have headache, both have maculopapular rash in many of the instances. So again, it's very difficult to discern Rocky Mountain spotted fever from Rickettsia parkeri rickettsiosis based on clinical features. Now, one of the biggest things that you'll notice is the very last line. Rickettsia parkeri rickettsiosis has resulted in 0 deaths thus far, whereas Rocky Mountain spotted fever, in this particular sample set, there was a 7% death rate. Treatment is the same for both, doxycycline. So it's one of those situations where you would rather treat somebody than not, but it is helpful to know which they have, as RMSF is so much more severe. The third, rickettsial pox, that we see here in the United States is predominantly an urban disease that's transmitted by mites that are found on mice. The pathogen occurs on several different continents, but the disease is almost never described beyond New York City. In fact, greater than 99% of the U.S. cases are from New York City, but we have identified cases in Baltimore, Boston, Trenton, Newark, and Philadelphia. It's relatively mild compared to other rickettsial diseases. Hasn't been studied extensively except for about 65 years ago. Cases occur year-round, and often family clusters are reported. People who are living in the same household, having that same exposure, you will see it in related family members. It's not a nationally notifiable disease, but in New York City it is indeed reportable. The majority of New York City cases originate in Manhattan on the Upper West End as well as the Bronx, and here in IDPB we see 3 to 5 cases each year. So on slide 32, a little bit more about rickettsial pox presentation. There is an eschar at the primary inoculation site that's described in 83 to 100% of the patients, generally on the extremities. Some of them even have multiples, and it may persist for 3 to 4 weeks and form a small scar. There is also a rash, similar to what you would see in Rickettsia parkeri rickettsiosis or Rocky Mountain spotted fever, and it follows the onset of fever by 1 to 4 days. There are small papulovesicles. They're relatively sparse and painless. They're found on the extremities, trunk, and face, but rarely on the palms and soles. And the severity of the rash is not necessarily indicative of how severe the illness is. There are also lesions that are found on the mucosa, on the tongue, the uvula, soft palate. That happens in 17 to 26% of cases. And there are small erosions or vesicles there that appear early in the disease course and are typically short-lived. Systemically, in rickettsial pox on slide 33, you'll see that there's a fever and headache and muscle aches within 2 to 7 days after the appearance of the eschar, and the fever is generally less severe than the other well-recognized rickettsiosis. Also, you will find conjunctivitis, pharyngitis, nausea, and vomiting, and if untreated, the disease persists for 7 to 10 days, but it's relatively mild compared to the other rickettsiosis and usually resolves on its own. However, hepatitis, photophobia, and nuchal rigidity have been reported. So if we look at slide 34, this is a slide comparing rashes of different types of diseases. You can see Rocky Mountain spotted fever on the upper left, rat bite fever on the lower left, a meningiococcemia on the upper right, and capnocytophica sepsis on the lower right. They all look very similar, which is why it's very nice to have a species-specific diagnosis to know which particular pathogen you're truly looking at in these instances. And again, if we look at slide 35, the eschar from rickettsial pox or Rickettsia parkeri rickettsiosis look very similar to that of, say, African tick bite fever or even a brown recluse bite. So it's very important to be able to distinguish exactly what pathogen we're working with if it's indeed an infectious agent. So slide 36 shows the immunohistochemistries of these 3 rickettsia species. And again, notably, there's nothing really notable to distinguish these. They all look very similar. So that's where molecular pathology and PCR really come in handy. So in IDPB, historically, we have used 2 different PCRs. The first is to the 17 kilodalton antigen gene that's present in all spotted fever group rickettsia. It's a nested PCR, so it is a bit timely. It produces a PCR product of 247 base pairs in the primary and 218 base pairs in the nested. And you can sequence the amplicon, and it'll essentially just tell you it's a rickettsia. It's not going to tell you any species-specific information. So when we can, we would then do PCR to the AMP-A gene. That's present in many of the spotted fever group rickettsia, but not in all of them. So it's lacking in Rickettsia australis, Rickettsia helvetica, Rickettsia acari, and Rickettsia bellii. Again, it's a nested PCR, so it does take some time. But the problem with this assay, while we get very nice amplicons that provide good species data, they're very big. So if you have a very fragmented sample, you're not going to get a positive that you can actually sequence. So one of the things that was really a goal here for us to be able to identify more cases was to develop some real-time PCR assays when those conventional assays failed us. So we have two different assays. The first just detects Rickettsia species. It's a small 74 base pair product, and it detects all spotted fever as well as typhus group Rickettsia except for Rickettsia bellii. It's to the citrate synthase gene, and this is a published assay by Stenos that came out in 2005. One of the things that I worked, though, to do was to create one assay to the AMP-B gene of Rickettsia acari, which is a 144 base pair product, and I teamed that with a couple of published assays, one to the AMP-B gene of Rickettsia parkeri, a 96 base pair product, and one specific to a hypothetical protein gene of Rickettsia rickettsii, in order to create a triplex real-time PCR assay. And with this assay, we were able to determine a species-specific diagnosis in very fragmented samples. 12 cases of Rocky Mountain spotted fever have been detected since this assay has started to be utilized. 7 cases of Rickettsia parkeri ricketsiosis, 11 cases of rickettsial pox, and 1 case of Rickettsia parkeri that was actually determined to be Rickettsia acari, which is very interesting. So with that, slide 39, I would like to just thank all of you for your kind attention, and my supervisor, Julie Batnagar, for all of her assistance with the presentation, as a couple of slides that she provided, as well as her general guidance from day to day. Chris Paddock is my former supervisor, who's in the Rickettsial Zoonoses branch now, who's been a wonderful mentor and helped a lot with the Rickettsial studies and getting those underway, as well as our branch chief, Sharif Zaki. So if you would like to contact me, I did list my email and phone numbers there. And if you would like any information from the CDC, we do have the address and the telephone number for CDC info listed on this particular slide. If you're interested in submitting specimens to the Infectious Diseases Pathology Branch, we do require prior consultation, and we have all of that information listed on our website. If they could show you the website link, you may contact us there, and there's lots of information on what types of specimens that you can submit and the types of testing that we can perform. So with that, I thank you all, and I'll open it up for questions.
Excellent presentation, Dr. Denison. Thank you for bringing that information to us. Before we get started with all of your questions, here's a quick reminder about how to reach us today. Questions can be sent via the green Q&A button at the lower left of the presentation window. We'll get to as many as we can. And our first question is, what is the nucleic acid amount range typically you collect from FFPE samples, and how much do you use Sanger sequencing?
Well, we have found over the years, at least with using nanodrop, that it's a little hard to determine the concentrations of these. They're very small amounts, typically in the nanogram. You know, some of them that we've used have been as low as a nanogram, maybe 10 nanograms per microliter. But it's hard to exactly say, because we will often find that due to the nature of formalin-fixed paraffin-embedded tissues, there are a lot of inhibitors in there. So at least the value that the nanodrop gives us is kind of false. So those are typically hard to determine for sure. What we typically do when we're running our reactions is we have a base amount that we will use. We will use 2.5 microliters in a 25 microliter PCR reaction or 5 microliters in a 50 microliter reaction of our nucleic acid. And all of that then will get run on our agarose gel when we've completed the PCR. And the entire amplicon then will be excised and extracted into a small enough volume that we can, depending on whether we're just going to use a single primer for sequencing or if we're going to use both a forward and reverse primer for sequencing, it'll give us just enough in order to perform the Sanger sequencing.
Do you perform molecular testing on fungal or yeast infection, and how would you screen for fungal infection?
We do not do that ourselves. As I mentioned, we collaborate a lot with the SMEs here at CDC. So with fungal specimens or suspected fungal specimens, if we see something that's suggestive of that on the H&Es or special stains, we'll send that to the mycotics division, and we essentially just send them scrolls, and they have their own extraction methods and PCRs that they will do to help us out with that.
Did you ever encounter new strains or species that are not found in the NCBI database? And what actions do you take to confirm new species or strains?
Because of the nature of the assays and the way that we run them, we typically are running something that's specific to a certain pathogen or a group of pathogens, say a pan-species assay. So if we are getting an amplicon, we're typically going to get a hit in the NCBI BLAST database. It's a matter of identity, how high the identity is. If we have something that's seemingly different enough, and again, it depends on which particular agent we're talking about. You know, with strep, some of those can have just a 1% difference between them, and those can be difficult to discern from one another. But with enteroviruses, there can be a somewhat broader range. And something that's 96% identity is still indeed an enterovirus. So again, that kind of depends, and if we have any questions based on the sequencing data that we get, we'll collaborate with the SME group here at CDC. We'll provide them extracts and then work back and forth to try to figure out exactly what it is that we are dealing with.
In performing microbiology but using molecular methods, can CGMBS perform these tests?
I'm not familiar with CGMBS.
Okay. While we are waiting for more questions to come in, I would like to once again thank Dr. Denison for her presentation. Another question for you. In a normal day in the CDC labs, how many samples are being processed? And how about when there's a large outbreak?
So that, again, varies with what's going on. In our lab, on a typical non-outbreak day, we probably would get maybe 5 cases in. And in terms of the molecular side, a case may constitute just a single block, or it may constitute 100 blocks. From there, it depends on how many are requested for testing. We may see 10 or 15 requests per week in a non-outbreak situation. Right now, with the Zika outbreak, our numbers are much higher, so we're probably performing about 60 maybe extractions per week just for phenylchloroform extracted RNA. Again, that depends on how many cases we get in per week, which varies highly. During the influenza outbreak in 2009, we were seeing probably a similar number come in. So we were definitely busy, considering that these extractions are a 2-day process. It's a timely thing. It takes a fair bit of time in order to get these, and then sadly we only get a minute quantity of nucleic acid in the end. So our number of tests is limited as well.
And for the last question, I'd like to clarify, when performing microbiology but using molecular methods, can clinical genetic molecular biologist scientists perform these tests?
I would imagine so. Yeah, most of these, a lot of these are published that we use. Either we will take something from another SME group here at CDC and adapt it to our specimens, but they're very typically just standard PCR reactions, standard sequencing reactions that I think any molecular biologist could perform.
Okay, and in the next question, TX is the first term used, so I'm going to assume it means Texas. So Texas doesn't have rickettsia causing ticks. How does the CDC molecular pathology manage other subtropical infectious diseases that make it in through South America travel?
Typically we rely on the clinicians and the clinical information that they provide to us. So we will, if there's a suspected case of, rickettsia from another country, say, we hope that the clinician is able to get travel information, travel history from the patient, and, we rely a lot on that, especially for the rickettsia cases. For other things, again, we rely on the local public health departments that will do surveillance in particular areas. Say, Florida is doing surveillance for Zika and dengue. I'm sure Texas is probably doing a lot of the same types of things in mosquito populations. And then, as they're seeing patients come in, I'm sure that these things are in the minds of the clinicians. And it's only, when the clinicians have issues that they have trouble diagnosing these, or if they want a specific confirmation, that those specimens will then come to us here in the Infectious Diseases Pathology Branch.
Which company makes the CDC's main software for consensus sequence assembly?
The CLC program that is used is made by QIAGEN.
CLC.
Yeah.
Okay. And again, while we're waiting for additional questions to come in, I would like to once again thank you, Dr. Denison, for your presentation. Do you have any final comments?
I am just so glad to be able to participate in this. It's been an interesting experience. I wish the webinar web camera would have worked. That would have been a definite nice added touch to it. But I definitely appreciate the opportunity, and I hope that this has raised some awareness as to what we do, and if there's anything that we can do to help the public health professionals out there, we'd love to offer our assistance.
Well, thank you. And I would also like to thank our sponsor, SciEx, for making it possible to bring this presentation to you. Today's webcast will be available for on-demand viewing through December 8th, 2016. You'll receive an email from us alerting you when it's available for on-demand viewing and posted on Labroots.com. You are welcome to forward this announcement to any colleagues who weren't able to join in today. We thank you for logging on and participating in today's broadcast, and see you next time.
Thank you.